Hello everyone. In today's session, we are going to continue with our topic viral hepatitis. It is a continuation to the chapter Epidemiology of Communicable Diseases. Viral hepatitis is a systemic disease with primary inflammation of liver. So with the term hepatitis, we know that it means the inflammation of liver. It is a viral infection. It is caused by the viruses. The most common cause of the inflammation of the liver, which is caused by the virus, are the five hepatotropic viruses. They are hepatitis A, B, C, D, and E. In addition to the nominal hepatitis viruses, the other viruses that can cause the inflammation of the liver include the herpes simplex virus, cytomegalovirus, Epstein-Barr virus, and yellow fever. So these are the other causes of inflammation of liver. Moving further to the types of viral hepatitis, we have viral hepatitis A, B, C, D, and E. The viral hepatitis A was discussed in detail in a previous session. You can find it in the playlist. Here, in today's session, we will completely focus on hepatitis B. So let us quickly go through it. Hepatitis A. Hepatitis A is caused by the single-stranded RNA virus which has no envelope, and the route of transmission was fecal-oral route. Children were more commonly affected. It has no carrier state and the incubation period was 10 to 50 days. Since it is an acute infection, so chronic infection is not found in cases of viral hepatitis. And the specific prophylaxis to viral hepatitis is immunoglobulins and vaccine. Similarly, let us discuss about viral hepatitis B. Have a quick brief intro and then followed by in detail we will discuss. The agent. So the agent factor, that is the causative agent of hepatitis B, is again a hepatitis B virus, which is a double-stranded DNA virus. Can you see the difference here? Hepatitis A is a single-stranded RNA, whereas hepatitis B is a double-stranded DNA virus. And hepatitis A has no envelope, whereas hepatitis B has an envelope. The route of transmission is parenteral route, vertical, and sexual. The children are commonly affected in hepatitis A, whereas hepatitis B can affect any age. The children, the adults, older people, all of them can be affected by hepatitis B. The carrier state is very common. So if the person is infected, then the wife can have hepatitis B. She can be a carrier with no visible signs and symptoms, but still the person can be infected. So the carrier state is common. Incubation period is 30 to 180 days. So we see that incubation period is quite long here compared to hepatitis A. It is 30 to 180 days. Chronic infection, hepatitis B is a chronic infection. It can lead to hepatocellular carcinoma. It can lead to fibrosis of the liver. So we see that chronic infection is commonly found in cases of viral hepatitis B. It is a chronic infection and the specific prophylaxis is immunoglobulin and vaccine again. So this was just a gist of viral hepatitis B. Let us understand in depth about each of it. So the viral hepatitis B was formerly known as serum hepatitis. So previously or formerly they used to call hepatitis B as serum hepatitis. It is an acute systemic infection with a major pathology in the liver. So we know that it can be acute as well as chronic infection. It is a systemic infection. There is a major pathology in the liver. So hepatitis B virus commonly causes pathology in the liver. Hepatitis B virus infection can either be acute or it can be chronic. It may range from asymptomatic infection, mild disease to most severe or fulminant hepatitis. Is it clear? What can the hepatitis B virus present itself as? It can present as a very asymptomatic case, very mild case, or a severe case, or fulminant. What is fulminant? Severe and sudden. Sudden plus very severe. Very severe cases, we call it as a fulminant case and a fulminant hepatitis. It is transmitted by the parenteral route most commonly. So we have acute hepatitis B and chronic hepatitis B. Acute hepatitis B will cause the liver inflammation. So there is inflammation of the liver. It will result in vomiting, jaundice. So the patient presents with jaundice. The liver inflammation results in jaundice, and we have vomiting, and rarely death can occur in cases of acute hepatitis B. Whereas in chronic hepatitis B, it will cause cirrhosis of the liver and liver cancer as well. Is it clear? Acute will cause inflammation, vomiting, jaundice, whereas chronic will cause liver cirrhosis and liver cancer. So let us discuss some more about acute hepatitis and chronic hepatitis. Acute hepatitis B is usually a self-limiting disease. As I said you, acute is very sudden short disease, so it is a self-limiting disease. It is marked by acute inflammation of the liver, and there is hepatocellular necrosis with the case fatality rate is 0.5 to 1% rate. Like I told you in the previous slide that the fatality rate is very low. Very rarely the death can occur. Okay, deaths are very rare. That is 0.5 to 1% cases there is death seen. And there is acute inflammation. Hepatocellular necrosis is seen in cases of acute hepatitis B. Moving further to chronic hepatitis B. Chronic cases, infection is encompassing a spectrum of disease. It is defined as a persistent HBV infection. So the infection is very persistent in cases of chronic. The persistent hepatitis B virus infection with or without associated active viral replication. There can be active viral replication, and there is hepatocellular injury and inflammation. You can find the evidence of hepatocellular injury and also inflammation. So chronic is not self-limiting. It does not get cured on its own. This is very self-limiting. It comes and goes away. Very common. Acute hepatitis B. There is acute inflammation. Fatality rate is very low. Whereas in chronic, there is hepatocellular injury, hepatocellular inflammation, and there is persistent HBV infection. And the virus, actively the virus can replicate. Okay, active virus replication can be found, or it can be absent as well. World hepatitis B is endemic throughout the world, especially in tropical and developing countries. So in the world, we are discussing about the epidemiology now. In the world, hepatitis B is endemic. So the endemicity of the active hepatitis B virus infection will be reflected in the serological prevalence of hepatitis B surface antigen in the general population of a defined geographical area. So we see that based upon the general population, the endemicity varies. Okay, so the endemicity, that is, it is in a usual frequency. Every year there are 100 cases of hepatitis B virus in that area. So the endemicity is prevalent in many major places in the world. Hepatitis B virus is very common. It is endemic throughout the world. It is an endemic disease throughout the world. Usual frequency, always the cases will be persisting. Okay, usually in the usual frequencies only. It doesn't go into the epidemics. Especially in tropical and developing countries, it is endemic. In general, it is more common in the lowest in the countries where there is high standards of living, and more common where there is low standards of living, where there is more hygiene and there is good treatment and everything. So their higher countries, more developed countries, the hepatitis B virus will be very low. Okay, whereas the developing countries, it remains as an endemic disease. It is seen to be high in tropical countries, developing countries, low in the high standard countries. Prevalence depend upon the mix of behavioral, environmental and host factors. So the prevalence of the disease depends upon the behavioral, environmental and host factors. Moving further, the hepatitis B virus global prevalence. So we see that again the endemicity of the HBV infection. How do we know? It is reflected upon the prevalence of the HBsAg antigen in the general population. HBsAg prevalence is 8%, defines high endemic areas. So we see that 8% 8% prevalence. Okay, whenever there is serological prevalence of the HBsAg, the surface antigen, I'll just write it down for you here, you'll get a better clarity. If the prevalence is of the HBsAg is 8% in the general population, then the defined geographical area is highly endemic. Okay, and then if the prevalence of the serological prevalence of this HBsAg antigen, if it is 5 to 7%, it defines the area to be high intermediate. And again, the serological prevalence of this HBsAg, hepatitis B surface antigen, in the general population of that geographical area, if the percentage is less than 2, then it is defined as a low endemic area. Is it clear? So let us see the areas here now. The high endemic areas, we have Africa, Middle East, Asia and then Europe. These are all the high endemic areas. Then we have intermediate and low areas, okay, like America, Latin America and all the areas, it is intermediate, and 2% very low area. North America very low. Okay, now we will move further. That also we have to know that again the prevalence will considerably vary, with the highest among the African. Here we see that it is highest, the high is in the Africans, which is 6.1%, and the Western Pacific regions it is 6.2%. Okay, is it clear? Now we will move further to the agent factor, that is under the epidemiological determinants. So far what did we discuss? We saw the definition, introduction to it, we saw the acute and the chronic type. What happens in acute? There will be inflammation, then hepatocellular necrosis, and it is a self-limiting disease. Chronic, there will be a persistent infection, hepatocellular carcinoma, liver cirrhosis will be there. Okay, and then we discussed about the problem statement, the high endemic areas, intermediate areas and the very low areas. That was about the problem statement. Now we are moving further to the epidemiological determinants. To begin with, the epidemiological determinants, we have agent factor, host factor and environmental factor. The triad, right? Agent factor, host factor and environmental factor. Let us discuss about the agent factor now. Agent is hepatitis B virus, which is a complex 42 nanometer double shell DNA virus. In the first slide itself, we had a gist. Under the gist, we studied that it is a DNA virus. It is double-stranded DNA virus measuring about 42 nanometer in size. It is originally known as a Dane particle. So we see that it will replicate in the liver cells. This Dane particle, which is given in the picture here, Dane particle, which is considered to be very infectious compared to the other forms. We have the Dane particle, which is very infectious and it will replicate in the liver cells. It is a double shell DNA virus. HBV, hepatitis B virus, will occur in the three morphological forms in the serum. They are the small spherical particles with an average diameter of 42 nanometer, and the filamentous or tubular form, the filamentous or tubules of a varying length, and they are of 22 nanometer in size. And third one we have the Dane particle. Okay. Is it clear? Let us see the picture here. This is the Dane particle, and we have out of the three serological types, first one is the spherical one measuring about 22 nanometer in size, and the filamentous form again measuring about 22 nanometer in size, and lastly we have the Dane particle, which is the most infectious one and the most common one, which is causing the infection. Okay, which is considered the Dane particle. Out of those three morphologies, it is considered very infectious. Other circulating morphological forms are are not infectious. Is it clear? The other two are not infectious, only Dane particle is infectious. What are the three types? Spherical, 22 nanometer in size, tubular form, again 22 nanometer in size, and we have the Dane particle. So in the Dane particle, I want you all to have a look. So we have this double-stranded DNA. You can see the double-stranded DNA here, and we have a lipid bilayer membrane and DNA polymerase, which helps in the replication of the virus. And we have the large surface protein HBsAg, which indicates there is a positive, which turns out positive on the test. It shows that the patient is having a current active infection, or he was previously infected with hepatitis B virus. So HBsAg specifically shows that the patient is infected, the surface antigen. Then we have medium surface protein HBsAg, small surface protein HBsAg. Then we have the core antigen HBcAg, and we have E antigen. All of these antigens we will discuss in the pathophysiology in detail about these antigens. I just want you to have a look at this. Okay, now we're moving further to the reservoir of infection. In the reservoir of infection, the men is the only reservoir of infection which can spread either from the carriers or from the cases. Very clear from the first slide itself that the patient can present itself as a carrier as well as a cases. So the active cases can also act as a reservoir of infection. Even the carriers will act as a reservoir of infection. Moving further to the infective material. The infective material is the contaminated blood is the main source. Viruses have been found in the body secretions like saliva, vaginal secretions, in the semen of an infected material or the infected man. In the semen, there can be the virus which is infective. So again, the wife can contract the infection and she can act as a carrier. And then also the vaginal secretions of that carrier, or she can also be an active case. And from the saliva also the virus spreads. So it is very important that we spread the awareness about it, that the virus can act very infective from the saliva, vaginal secretions, and semen of an infected material. Moving further to the resistance, it is readily destroyed by the sodium hypochlorite as is by the heat sterilization in an autoclave for 30 to 60 minutes. So we see that the virus can be destroyed by sodium hypochlorite. It can be destroyed by heat sterilization. Two methods we can destroy the virus: sodium hypochlorite solution and heat sterilization. Like we can autoclave it for 30 to 60 minutes and we can destroy the virus. Moving further to the host factor. Starting with age. Acute hepatitis B. The outcomes of HBV infection are age dependent. Acute hepatitis B occurs in approximately 1% of the perinatal, 10% of the early childhood, that is 1 to 5 years of age, and 30% of the late more than 5 years of age HBV infections. Is it clear? What did we understand? Acute hepatitis B, we are discussing that it is age dependent. Okay, let us just mark it here. It is age dependent. It occurs 1% in perinatal, 10% in childhood, 30% in the late infection. So 90% will resolve by themselves. Acute hepatitis, I told you, it is a self-limiting disease. So they will resolve by themselves. Very rarely, less than 1% will develop the fulminant hepatic failure. Is it clear? Now we go to the chronic hepatitis B. 2 to 10% will progress to the chronic state. It will occur in approximately 95%, that is 95% in perinatal and 80% in childhood, that is we have 1 to 5 years of age, and after 5 years of age it is 5 to 10%. Is it clear? The chronic hepatitis B. What do we have? The perinatal. Acute is more commonly, acute is occurring in the children more than 5 years of age, and chronic hepatitis B more commonly seen in the perinatal period. In 95% it is in the perinatal period. Moving further to the high risk group. The mortality rate increases among the HIV positive people. So we see the high risk groups, the HIV people being more prone to HBV infections, and the annual incidence is also seen in the surgeons, which is 50 times greater than the general population. The other high risk groups are the recipients of the blood transfusion, healthcare and lab personnels, homosexuals, prostitutes, percutaneous drug abusers, and the infants of HBV carrier mothers, recipients of solid organ transplants, and the patients who are immunocompromised. So we see the high risk groups are those who have the constant contact with the blood. So if the blood transfusion is done and that blood contains the hepatitis B virus, then it can result in the transmission of infection to the healthy individual. So the high risk groups are those who have repeated blood transfusions and those who work in the healthcare facilities, because it is spreading by the saliva secretions. So we have the healthcare and lab personnels, homosexuals, prostitutes, percutaneous drug abusers, because they have again contact, usually they are in contact with those infected syringes, needles, they share this needles, and that sharing of the needles will result in the transmission of infection very easily from one person to other. And the infants of the HBV carrier mother, if a person is infected, assume he is a drug abuser, he has got it from other friend, and now his wife again will be a carrier, and the infant who is born to this couple can also be contracted with HBV. HBV carrier mothers, recipients of solid organ transplants as well, and the patients especially who are immunocompromised, like I told you, patients who are suffering with HIV. Hepatitis B and HIV has a very close correlation. The HIV will be, the patient will already be immunocompromised, so what happens, the mortality rate will be increased among the HIV positive people, because there is a co-infection between the hepatitis B virus. Both hepatitis B virus and HIV can be contracted in the same individual, and this is increasing the risk of liver cirrhosis and hepatocellular carcinoma. Is it clear? A person, he might be already HIV positive, he is HIV positive, then very easily he can okay, I'm so sorry, yeah, the patient is already HIV positive, and now what happens, he is immunocompromised. The patient is immunocompromised, very easily HBV can affect him, so he can contract both HIV plus HBV both together, and this will lead to hepatocellular carcinoma, and it can also result in fibrosis, hepatic failure, cirrhosis of liver, etc. Moving further to the humoral and cellular responses. Hepatitis B virus has three distinct antigens. So we have hepatitis B surface antigen, hepatitis B core antigen, and hepatitis B E antigen, which is an envelope antigen. It is surface antigen is also known as Australian antigen, and we have hepatitis C antigen known as a core antigen, and hepatitis B E antigen is an enveloped antigen. They stimulate the production of the corresponding antibodies, which will be discussed in the next slide. Okay, the three antigens, what you have to remember, what are those? The three antigens: hepatitis B surface antigen, which will be positive in the infection, hepatitis B C antigen, core antigen, hepatitis B E antigen, that is envelope antigen. Incubation period is 30 to 180 days, 50 to 180 days, 45 to 180 days, 180 days, and this the first number varies, okay, between 30 to 60. Usually it is 60 to 90 days. Okay, on an average you can write 50 to 180. Okay. Okay, let's move further to the mode of transmission. The mode of transmission is parenteral, that is, IV drug abusers, health workers, and are at an increased risk. Sexual, the sex workers, the sex workers and homosexuals are particularly at risk. Then we have perinatal. The mother, that is hepatitis B antigen positive infant, mothers who are hepatitis B E envelope antigen positive, they are much likely to transmit these infection to the offsprings than those who are not infected. The perinatal transmission will be the main means of transmission, especially in the high prevalence populations. The other routes of transmission will include the horizontal transmission from the child to the child. It is responsible for the majority of the hepatitis B virus infection and carriers in parts of the world other than the Asia. So the horizontal transmission is also one of the cause. Okay, it is a majority of the causes of HBV infection. Is it clear? What are the modes of transmission? We have parenteral, sexual, perinatal. Okay, parenteral is by IV line. You remember parenteral is IV line. So IV can be by the drug abusers, again the needles, health workers, IV, they are at an increased risk. Sexual, sex workers, homosexuals. Perinatal, from the mother to the infant. It is a vertical transmission. Okay, mother to the infant. The other routes were the horizontal. Child to child is responsible for the majority of HBV infections. So we have direct blood to blood contact, mother to child during childbirth, and that is sharing the needles and the syringes, tattoos, piercing. The barbers can transmit the infection from the infected. The blade can be used. If the infected blade, the blade is having the blood of a previous person who is infected with hepatitis B virus, and now the healthy individual has come and the barber has used the same blade to shave the other person's head. So that is how the hepatitis B virus infection will spread from one person to the other person. And we have scarification, circumcision. All these practices can also result in the transmission of infection to the perinatals. And then we have sharing needles. If the healthcare workers are not using the needles properly, or the drug abusers are abusing the needles, then it can spread the transmission of the infection. Transmission of infection can occur also by the household contact, like sharing the hygiene equipments like the razors, toothbrushes, earrings, etc. And the unsterile healthcare practices, as I told you earlier. And also we have the sexual transmission. There is a risk during any type of sexual contact, because even the saliva contains the hepatitis B virus. So the saliva, the semen, the vaginal secretions, all of these are containing a high risk of transmission of hepatitis B virus. Is it clear? Now let us discuss about the pathophysiology. We have the hepatitis B virus DNA, which is consisting of the 4 overlapping genes which are encoding the multiple proteins. So I told you about the genes, the S gene, P gene, C gene and X gene. Let us discuss in detail. The X gene, we have added the X gene here. Previous slide we have just 3 genes. We will also include the medicine aspect as well. Okay, I have added all of these slides from the medicine, so that you can have an in-depth understanding. You don't have to do the topic in PSM and again go back to medicine. It is a combination of all the medicine as well as the PSM, preventive and social aspect also will be included in the same lecture, so that we have a clear and the topic has to be very clear to us. For that we need to know the pathophysiology. It is very important. So we see that the S gene, which is code for the surface envelope protein, the S gene stands for the surface, HBS. S stands for the surface. The surface protein, that surface antigen, it is the main indicator of active infection. As I told you earlier, that it is the main main indicator of active infection. Whenever we write the test in our OPD basis and all, what do? We write HBsAg and the test turns out to be HBsAg positive or HBsAg negative, which indicates whether the patient is having an active infection or not. Next, we have the P gene. P gene is the largest and it codes for the DNA polymerase. And we have the C gene. C gene will code for two proteins, HBeAg and a core protein HBcAg. This is the envelope protein and this is a core protein. X gene will code for the non-particulate protein HBxAg. Is it clear? What are the four genes? S gene coding for HBsAg. P gene coding for the DNA polymerase. P stands for the polymerase. And we have C gene which codes for the core protein HBcAg and HBeAg. And we have X gene which codes for HBxAg. So let us discuss in detail about HBsAg. It appears in the blood after 6 weeks of infection. Now, when does the patient turns out to be HBsAg positive? After 6 weeks of infection. Its detection will show that HBV infection is positive. So, when the test HBV, hepatitis B virus infection turns out positive, it shows that the patient is having the active infection. And this HBsAg will usually disappear in 3 to 6 months. It disappears. If it is persisting even after the 6 months, it implicates that the person is a carrier state and may be demonstrated in chronic hepatitis patient. Okay, a carrier state will be demonstrated in a chronic hepatitis patient. Even after 6 months HBsAg is positive, it usually will disappear within 6 months. Even if it is persisting, it shows that a person is in a carrier state and a chronic infectious state. And anti-HBs. After the 3 months of onset, the antibody to HBsAg appears. Very simple, okay. What you're going to do? The surface antigen is HBsAg, okay. Antigen stands for Ag. Now it is an antibody, right? So the antibody is against the HBs. You don't have to get confused. Very simple. Antibody to HBs. So it is anti-HBs. Antibody to HBs is anti-HBs. It will appear 3 months after the onset of the HBsAg. Okay. Once the antigen comes up, okay, HBsAg has come in, and after the 3 months of onset, then what happens? The specific antibody will develop. Moving further to HBeAg, envelope antigen. It is present during the acute attack. Okay, in 6 weeks it will be there. It is present during the acute attack. If it is still persisting, it shows that the patient has developed a chronic liver disease or he has developed a carrier state. Very simple, just like the previous one. HBeAg also shows that the person usually it will disappear within 6 weeks. If it is persisting, it shows that there is chronic liver disease and a carrier state. And again, an antibody to HBe appears. The antibody to HBe is known as anti-HBe. Antibody to HBeAg will appear after the disappearance of antigen. So the HBeAg antigen will disappear. Only then the antibodies will be shown. The seroconversion of this antigen to the antibody during the acute state shows that there is a resolution of infection. So what did you understand by this? Very simple. Let me just zoom in and write it for you. So here, first the person will develop HBeAg. The antigen is showing that the person has an infection. Now what happens? The body has to fight away this antigen. So what happens? The antibodies to the HBe will appear in the body. So once the E appears and then anti-HBe appears, so the disappearance of this and the appearance of this shows that there is a resolution of infection. The person has got cured. No more he is infective. No more the HBeAg is positive. It is just antibodies to the HBe has come up. Moving further to HBCAG, it is a core protein. It cannot be detected in the blood. So please understand that it is a core protein. It is found in the nuclei, in the core, in the nuclei. So it cannot be found in the blood. It can HBCAG can be demonstrated in the nuclei of the hepatocyte. So to demonstrate the core protein, we have to see in the nuclei of the hepatocyte it can be found. And a carrier state and in the chronic hepatitis we see the HBCAG. And now we see that anti-HBC, antibody to the HBCAG can be detected in acute hepatitis B during the pre-icteric state. Okay, in the acute stages we see during the pre-icteric stage we can find the antibody to the HBC, and the antigens are found in the carrier state in the chronic hepatitis. Now these antibodies can be in the form of IgM, or antibody can be in the form of IgG. IgM, obviously it will show an acute infection. It will persist for 4 to 6 months. IgG will show some past infection. Whenever there is an IgG, in our previous so many lectures we have discussed multiple times, IgM indicates recent infection, acute infection, persists for 4 to 6 months, it will be there. More than 6 months or a past infection, the IgG will be seen. Then we have HBV DNA. It presents in the pre-symptomatic phase and the early acute stage. Is it clear? It is seen in the pre-symptomatic. The patient has not presented with all the signs and symptoms. So it will be present in the pre-symptomatic stage and in the early acute stage. So we'll move further to the symptoms of hepatitis B. They include jaundice, fever, dark urine, pale poop, nausea, vomiting, pain in the right side of the abdomen. Obviously the liver, there is inflammation, so there is pain in the right side of the abdomen, right hypochondriac region, joint pain, fever, hives, and then we have headache, weakness, fatigue, loss of appetite. Is it clear? What are the symptoms? Very important that there is dark urine and pale stools. Okay, the stools will be pale and urine is going to be dark. Fever, jaundice, abdominal pain, anorexia, nausea, vomiting, all of these. Okay, loss of appetite. Very simple. The signs and symptoms are very easy to remember. Moving further to the diagnosis. Diagnosis will include the serology. We have the serology, the detection of the several antigens and their antibodies. They are important in identifying the stage of HBV infection. So the serology plays a very important role because we need to detect those antigens and the antibodies. We need to know what stage it is. Is it an acute infection or is it a chronic infection? Which antigen has come? So if there is an HBsAg, which is an indicating of active infection, if it is negative, if HBsAg is negative, it shows that the infection is unlikely in this patient. If it is positive, it shows that there is an active infection. And the core antigen which we find in the nuclei of the hepatocytes, then again we see the chronic infection, the carrier state, IgM antibodies, if they are come, it shows an acute infection. If it is IgG, it is a chronic infection. Okay. If there is HBeAg, which is a part of the core protein, they can be used as an indicator of the viral replication. Is it clear? The serology. Then we have a liver chemistry test. And the liver chemistry test, we have AST, ALT, and increased ALP and total bilirubin. Now, the elevated AST, ALT. AST, okay, the AST stands for aspartate aminotransferase, and the ALP will stand for alanine aminotransferase. These will be the most sensitive indicators of liver cell damage whenever there is some damage to the hepatocytes. Very important, very basic, that when we come up with the reports, we see that ALT level has increased, AST has increased, SGPT, SGOT, if it has increased, it is a very sensitive indicator that there is some liver cell damage, and it will be significantly elevated, especially in cases of acute hepatitis B infection. And then we have ALP elevation. So, while not as prominent as AST and ALT, ALP can also be elevated in some cases of hepatitis B. Especially if there is bile duct obstruction, ALP can be elevated. Main important, AST ALT will be elevated. More prominent is AST ALT. Okay, aspartate aminotransferase and alanine aminotransferase. And then we see that there is bilirubin increase. The high total bilirubin levels can manifest itself as a jaundice, where the patient will present with the yellow skin and yellowing of the eyes. It is because there is an inability of the liver to properly process the bilirubin. Okay, the liver is not able to process the bilirubin properly. Also, we discuss about the dark urine and the pale stools. Also, you need to know about it. Now we know that there is inflammation, then the bilirubin is not processed properly, so that is resulting in jaundice. Now, what about this dark urine and the pale stool? Why does the patient presents with the dark urine? And why pale stools and hepatitis B virus infection? So, when the liver is damaged by the hepatitis B virus, now let us see this liver, it is damaged by the hepatitis B virus. The liver no longer is in the ability to process the bilirubin. It can't properly process the bilirubin. It will lead to the accumulation of the bilirubin in the blood, and that blood will be again excreted. It will be purified by the kidneys and excreted in the urine. So the urine will contain too much of the bilirubin extracts in it, and that will be secreted in the urine, making the urine to appear very dark. What did we understand? When liver not processing bilirubin, it is in the blood, and the blood will go to the, it is in the blood, and in the kidneys the blood gets purified, and then it is the waste is excreted by the kidneys in the urine, and the urine will appear dark. Now what about the pale stools? Why pale stools? Dark urine is often seen along with this jaundice, and because of the high level of the bilirubin, whereas the pale stool is because the bilirubin isn't secreted in the intestine. Okay, since the liver is not able to process the bilirubin properly, what is the function of the bilirubin? What does it do? It is secreted in the intestines as a part of a bile, and then that will give a color to the stools. But here, since the liver is not able to process the bilirubin properly, the bilirubin is not excreted in the stools, making the stools to appear very pale. And since the bilirubin is remaining in the blood, it is getting filtered out and the urine appears very dark. Make sense? Now let us move further to the histology, that is immunoperoxidase staining. In the histology we have immunoperoxidase staining. Okay, and then we have HBV viral DNA, which is the most accurate marker. HBV DNA will be the most accurate marker of the viral DNA, and it is detected by PCR, okay, polymerase chain reaction. And about the immunoperoxidase staining, it is a laboratory technique where we identify the hepatitis B viral antigens, especially the surface antigen, the core antigen, with the tissue samples which are taken. Liver tissue samples will be taken. We do the liver biopsy, take the samples, and we assess whether there is a chronic hepatitis B infection by visualizing the antigens within the hepatocyte using a microscope. Okay, and essentially it is a way to stain the virus within the liver tissues to see how much of these viruses are present, which stage. Okay, what are the antigens which are present. Immunoperoxidase staining, we stain and we observe under the microscope. First, what do? Liver biopsy, take the tissue sample, liver tissue sample, stain it, observe under the microscope, and we identify the presence of hepatitis B viral antigens. Then we have hepatitis B virus DNA, which is a measure the amount of HBV in the blood. Okay, hepatitis B virus DNA is measured especially in the blood. It is used to monitor the HBV infection and how the treatment response is. Whenever the viral load will be very high, it shows that more active infection is going on, and there is a greater risk of the liver damage. Okay. And then we have liver biopsy to determine the grade, the inflammation, and the fibrosis, the stages of the liver affection, and the chronic hepatitis. Then moving further to the prevention. Since there is no specific treatment for HBV, prevention is a major aim in managing the viral hepatitis B. So the following measures are available. We have the vaccination. It is highly effective recombinant vaccination. So we see that the recombinant hepatitis B vaccine, which was introduced in 1986, and then we have hepatitis B immunoglobulins, HBIG immunoglobulins. They are exposed within 48 hours of the incident, or neonates whose mothers are HBsAg and HBeAg positive. Okay. Other measures will include the screening and the screening of the blood donors, blood and body fluid. Okay, we screen the blood before the blood transfusion, screening of those blood donors before the transfusion, and the body fluid precautions have to be taken. If the person is infected, the wife have to be said to avoid any sort of sexual contact with the infected individual, else she will end up being a carrier. Then we will move further to the hepatitis B vaccine. The recombinant hepatitis B vaccine was introduced in the year 1986, and the active substance in the recombinant hepatitis B vaccine is HBsAg. So we know the active substance is the hepatitis B surface antigen. The hepatitis B vaccine is available as a monovalent formulation, or it is found in the fixed combination with the other vaccines. The other vaccines will include DPT, hepatitis B. Then we have hepatitis A and inactivated polio. The other vaccines like DPT, inactivated polio, the hepatitis B virus vaccine can be used in combination, or it can also be used singly in a monovalent formulation. Okay, the monovalent hepatitis B vaccine is only used at birth. At birth, only the monovalent B has to be used. The dose for the adults is 10 to 20 micrograms initially, and again at 1 and 6 months it has to be administered. Okay, let me just mark it for you. Okay, the active substance, we discussed about the active substance, and we saw that it is found in a monovalent formulation, or it can be found in the combination as well. It can be found along with the polio, along with the polio vaccine. It can be given DPT vaccine, it can be included, or monovalently you can give, but especially at birth the monovalent is preferred. Then we are discussing about the dose. For the adults, 10 to 20 micrograms initially, again at 1 and 6 months we give. And for the children under 10 years of age, half the dose of the adult. Okay, at the same time interval, 1 and 6 months, we give half the dose. Then the vaccine is the deltoid muscle is preferred for the vaccine. And then for the infants and the children under 2 years, the anterolateral aspect of the thigh. Okay, the anterolateral aspects of the thigh is used as a vaccination site. And the routine pre-exposure vaccination is considered for the group of adults who are at an increased risk of HBV infection. So before the exposure, pre-exposure vaccination is done for the high-risk groups. Is it clear? Okay. So that there is a greatest reliability of absorption, the deltoid muscle will be preferred for injection rather than the gluteal injection. We give it in the deltoid so that the absorption can occur. And then if we give it in the gluteal region, then what happens? The gluteal injection will result in the deposition of the vaccine in the fat rather than the muscle. It will get deposited in the fat with fewer serological conversions. Okay, especially for the children and infants, we give in the anterolateral aspects of the thigh. Then we saw that in adults, the routine pre-exposure vaccination is done, especially for those who are at an increased risk of HBV infection. Adults 20 years of age and older should receive 1 ml of the adult formulations. Is it clear? Then we move further to the high risk groups. We have discussed about it. The high risk groups are those who are having high risk sexual behavior, and then we have partners, household contacts of HBsAg positive persons, injecting drug users, those who frequently require blood products, blood transfusion, and recipients of the organ transplantation. Occupational risk of HBV infection include the healthcare workers as well as the international travelers to HBV endemic countries. Okay, we saw the HBV endemic countries, especially the developing countries like Asia. So those international travelers traveling to the endemic countries can contract the infection. They are also at a high risk group. Okay, then what are the contraindications to this vaccine? The hepatitis B vaccine is contraindicated for the individuals who are having an allergic reaction to any of the vaccine components. Okay, those who are having an allergic reaction, it is contraindicated. Neither the pregnancy nor the lactation is a contraindication. You can give this vaccine in pregnancy, you can give this vaccine to the lactating mothers. The vaccine should be stored at 2 to 8 degrees Celsius. Okay, then the freezing must be avoided as it dissociates the antigen from the alum adjuvant. Is it clear? Freezing is not recommended for the vaccine. It is stored at 2 to 8 degrees Celsius. Now we move further to the treatment. There is no specific treatment for the acute hepatitis B. Care is aimed at maintaining the comfort, giving them additional and adequate nutritional balance, including the replacement of the fluids which are lost because of the vomiting, because of the diarrhea. We need to replace the fluids in the patients, and then give them adequate nutrition, maintain the comfort. And then we have in the treatment aspect, we have interferon alpha, which is a drug used to treat the chronic hepatitis B. It is an antiviral cytokine which will inhibit the viral replication. It will reduce the virus in the body, shortens the duration of the virus shedding. Okay, and then we see lamivudine. Again, it is a virus where there is, it is indicated especially when there is a relapse of infection, and if the patient has a drug resistance, we can think of lamivudine. And we also have adifovir dipivoxil. It is given especially in chronic hepatitis B virus infections. Moving further to the national immunization schedule, the birth dose is very crucial. So the hepatitis B is given at birth or as soon as possible within the 24 hours, because the first dose given at birth is critical, because it provides the immediate protection against the potential exposure to the virus during delivery. Even if the infected mother is delivering the delivery, it will give us an immediate protection to the newborn infant. So the first dose is very critical, and the subsequent doses are given at 6, 10 and 14 weeks. Okay, let us see. The first dose, hepatitis B, the first dose is given at birth as soon as possible, followed by the other doses 1, 2 and 3 are given at 6, 10. Okay, the first dose 0 is given at birth, and 1, 2 and 3 is given at 6, 10 and 14 weeks. The dose is 0.5 ml in both intramuscular region, and in the infant it is anterolateral aspect of the mid-thigh, and again at 6, 10 and 14 weeks, again it is given on the anterolateral side of the mid-thigh. So thanks for watching. With this we come to an end of the session of hepatitis B virus. In the next sessions we will discuss about hepatitis C, D and E. I hope you follow all the lectures and gain the maximum understanding. I hope you like the lecture, and if you like it, hit the like button and subscribe.